Brilliant. Well, welcome everyone. I hope that you can hear us and that you can see us. I'm just going to give it a couple of seconds for people to join. Okay. Okay, so we've got some people here. So welcome everyone. Welcome to this webinar for RCEM's Time Critical Medications 2025 National Report. Firstly, this meeting is being recorded. We'll share the recording on RCEM's Quality Improvement webpage in about a week or so's time, so do keep an eye out. The national report is now published alongside a press release. I'll put the links to this in the chat. So after we're done, go and have a look at that. So what we're going to do today is we're going to cover the 2025 national results. Then we'll have a look at a couple of case studies from some high-performing sites. And then there'll be an opportunity to ask any questions. As we go along, please feel free to ask anything in the chat, have some discussions. This is a resource to help you continue to take part in 2026 and moving forward. So to take you through today, we have Johnny and Ali from the TCM topic team who have worked really hard over the past couple of years to bring you the TCM QIP. So Johnny, thank you again, and I will hand it over to you for standard one.
Lovely, thank you, Amy. Thanks a lot. Hello, good afternoon, everybody. So we're going to take you through the three standards, and then we're going to take you through, as Amy said, some case reports which show good practice at a local level that you may be able to apply to your own situation. So standard one, as you know, there are three standards in this QIP. We're halfway through, well, more than halfway through the process now. So it originally was a 3-year QIP. It's now a 4-year QIP, and this report today is basically this at the end of the second year. So from the 1st of January 2025 to the 31st of December 2025. So standard one was basically the percentage of patients who were identified as being on a time critical medication within 30 minutes of arrival. And if you remember, you all know that the college produced a safety flash back in November, I think 23, that said a missed time critical medication dose can cause harm. That was the mnemonic for all the time critical medications that they felt were time critical. And of those two, there are 2 medications that need to be given within half an hour because it'll cause adverse clinical effects to the patient. One is levodopa in Parkinson's, and the other, of course, is insulin in insulin-treated diabetics. So whenever I refer to as being on a time critical medication in this presentation, referring to patients on oral levodopa with Parkinson's or on insulin for insulin-treated diabetes. So this is what it showed. This was the SPC chart for the whole of the data set, which was around 18,500 cases. So it was similar to year one in numbers. So year one, 46.6% of people were identified within 30 minutes of arrival who are on a time critical medication, and the focus in year one really was to try to increase that number up, but unfortunately that hasn't proved to be the case, because the year two result is 44.44%, so it's actually gone down slightly, but not it's not statistically significant. It hasn't statistically significantly gone down. So we're happy in a sense that it stayed static. There was a risk that this could have gone down because obviously EDs are getting busy. You know, we were worried people would disengage with the QIP because it is a lot of work. And thank you for all your hard work. And we were waiting on the dashboard to come. And you know, I know people were putting in a lot of data on a weekly basis and not getting anything back. But hopefully now that the report's out, that the dashboard's up and running, you can see the impact that your interventions are having. So the identification rate for levodopa and insulin were pretty much similar, and the identification of patients receiving insulin fell slightly. So So that's the SPC chart for standard 1. Now, if you look at this graph, which is basically the green, so the purple line is the SPC chart from standard 1. The green graph with the green that's filled in, that is the national occupancy of EDs across 2025. And you'll see that when an ED is overcrowded, so the peaks of the green, when ED is overcrowded, it seems to suggest that it takes longer to identify people on a time-critical medication. And that makes sense when I explain who did the identification in the next slide. But when you look at periods of less overcrowding, so in the middle of that graph, you'll see from roughly April to August, you'll see on the graph, it suggests when there is flow in emergency departments, then patients are more likely to be identified as taking a time-critical medication from the way that they're being identified at the minute. So crowding is a factor, but it can be overcome. So if we're going to the next slide. So the top graph basically shows you the average time it took to identify. It was 116 minutes in year 1 and went down to 110 minutes in year 2. So 6 minutes is not a statistically significant improvement. We want to see it much quicker than that. The pie chart shows who identified patients. So there was a big drive to get identification earlier in the patient journey. So we were hoping that between year 1 and year 2, more patients would be identified by the triage nurse and more patients would be identified by the ED receptionist. But that didn't happen either. So it was still 42% of people were being identified by the named clinician, 37.8% were identified by the triage nurse, and only 4% by reception staff. And that's year 2 result. Year 1, it was 3.76. And the significance of that is this. On average, it took 6 minutes for the reception staff to identify the patient was on time-critical medication. It took 30 minutes on average for the triage nurse to do that. And it took over nearly 3 hours for the named clinician to do that. So if the vast majority of people are being identified by a named clinician, it's not rocket science to work out why standard 1 didn't increase, why we weren't identifying, and why that SPC chart didn't change, because the vast majority of patients are still being identified by the named clinician, just over 40%. So we need to shift the identification towards the front door. We have looked at individual cases, and we'll talk about those after we've gone through the 3 standards that will show that it doesn't matter if your department's overcrowded, you can still identify early. And we'll talk about that. We'll talk about that soon. So I'm just going to hand over to Ali now to go through standard 2.
Thanks very much, Johnny. So hello, my name is Ali Cracknell. I'm a consultant geriatrician in Leeds, but I support Johnny and Amy and the team on the Time Critical Meds QIP, and it's an absolute pleasure to be involved in this. And I see day to day how if we get this right in the ED department, how it filters down for vulnerable patients who are admitted to wards. If we get it right in ED, then that follows into their admission, and they're much less likely to have side effects and complications of having missed medication. So thank you for all your work, and this is really impressive QIP that the RCEM are supporting with all you guys. The standard 2 was looking at all time critical meds and whether they are administered within 30 minutes of their due time. So the top chart shows the SPC chart for year 2 data. There's been no overall change across the year, and results are pretty similar to last year with no statistically significant improvement, but there is a slight increase overall from 32.4% of medicines being administered within 30 minutes to 33.8% in year 2. And we've seen the improvement more within insulin doses this year, 26.6% of insulin doses are administered within the 30 minutes. That's up from 22 last year. And levodopa, not really significant change across the year. And when we look at the average time to administer time critical medication, that's the bottom chart there. The average time is 185 minutes from its due time. So that is nearly 3 hours. So obviously some room for improvement, but accepting the challenges of working in ED in overcrowded departments. And the range is 72 minutes to 259 minutes. But one of the key findings here, if we look at the patients who are self-administering their own doses, the average time for them is 37 minutes. So although only a small proportion currently are self-administrating, we'll come on to that, it's about 13%. If we can crack or improve the numbers self-administrating, then that's going to make a big difference because they're much more likely to get the medication on time. So really standard 2 here highlights the need for, as following on from identification of the patients, that once we're identified, we need accurate medication lists. We need a supply of the medication available in ED, and we need to support those that can to self-administer wherever possible. Thanks, Amy. So this is looking at the self-administered doses. So this is a great news story here because this SPC chart is the data from year 2, and you can see we've had a statistically significant improvement around August time. I don't know if you just want to highlight that, Amy, if you can. So we've had a run of over 8 points above the early mean later on in the year from August. So we are now seeing 75.7% of patients who are able to self-administer the meds doing so within 30 minutes. So that is absolutely brilliant and quite a massive change from year 1 where it was 66%. We seem to be better at supporting people on levodopa to self-administer, 78%, compared to insulin, which is a little bit lower in terms of getting it within 30 minutes. So that's great, but a small proportion overall are actually self-administered doses. So as I said, systems that can support us to identify patients who are able to self-administer and empowering them to do so is likely to make a big impact and actually reduce pressure on stretched ED staff as well. Thanks, Amy. And standard 3 is also a good news story. So this is looking at the percentage of patients who haven't missed a time critical medicine dose whilst in the ED department. So again, you can see there's been a step improvement in the year 2 data here. It's increased from 51.5% at the beginning of 2025 to 58.4% across the latter part of the year, and that again is a significant improvement from year 1 when it was running about 55%. So that is great. We're missing less doses in total, which is brilliant news. Well done. And again, there's not much difference between levodopa and insulin, but it's slightly higher in insulin in terms of less doses missed altogether. Self-administered time critical medicine is very similar to year 1, with some results of 60% of doses administered overall, which is good. And as Johnny said, higher rates of missed doses correlate with periods of ED overcrowding. So again, if we can work on self-administration, that is likely to be key to our success going forward. So I'll hand back over to Johnny.
Thanks very much, Ali. So those three standards we've just summarised in this slide. So overall, there's been consistent performance between 2023-24 year one and 2025-2. Obviously, standard one, 44% of patients were identified within 30 minutes, which is a reduction of 2.6%, but that's not statistically significant. Standard two, the percentage of time critical medication administered within 30 minutes with expected time, again, it's gone up by 1.5%, but it's not statistically significant. Whereas standard two, the percentage of time critical medication that was self-administered within 30 minutes, the good news point in this webinar, has gone up by 9.5%, which is statistically significant, so that's great. And then standard three, again, is 57%. So if we go on the next slide, I'm going to share with you now this. So you may recognize this, which is basically it's what we call the chain of TCMs, and it's really important because if we can get these four things right, I think we're going to get increased performance in all three standards. So early recognition, I think there needs to be a lot of work on recognizing early. So you need to go back into your trust and look at your systems and see, can you identify people earlier? Because the earlier you identify them, the better. We found that the people were more likely to get their time critical medication after they arrived at 11 o'clock at night, because nobody takes time critical medication between roughly 11 and sort of 6 or 7 in the morning. So people that weren't identifying at reception, they basically had 8 hours to find them, and then they could prescribe them. So what we're saying is it's much easier to try to identify them earlier in their journey, either through ED reception or the assessment team or the triage nurse. That's the first one. The second one then is around early prescribing, and that's really empowerment of the ED triage nurse or the assessment team. So if reception identifying, they can put a tag on that basically shows the triage nurse or the assessment team that this patient is on a time critical medication, they can then put in place an assessment for, can they self-administer, and if they can, let them. If they can't, ensure that the time critical medication is prescribed early, and they get somebody to do that. The third one is access to meds. So the organisational data in the QIP, you'll see in the report, we've got a lot better with across organisations for access to time critical medications within emergency departments. So that link's working well. And then obviously the last one is, once a patient has been given the meds, they should take them in a timely manner. And that chain disappears if people can self-administer, in a sense. And they are self-administering, because I was talking to one of the pharmacists at the NHS England the other day, and they said, if a patient walks into an ED with time critical medication on them, there's no reason why they shouldn't be able to take them and walk out again. And that is true. That is true, because at the minute you will have people sitting in your waiting room every day who are taking their time critical medication, who are giving themselves their insulin, who are taking their levodopa, and you don't actually know about it until they come into the main department. So just bear in mind that the chain of TCMs, that's what we're focusing on in year 3. So a couple of examples then. So this is Northampton General Hospital, and what they did was in halfway through year 2, they introduced a screening question at ED reception, and basically it was a mandatory question that basically said, are you on a time critical medication? Are you on levodopa for Parkinson's or insulin for diabetes? And you can see that intervention resulted, so the performance was way below the mean pre-July. Whenever they introduced the question, took a bit of time to build up, but that resulted in 11 consecutive 11 consecutive points above the median on the SPC chart from July onwards to December. You can see it at the right hand side at the top of that graph, the yellow dots, and their performance increased from 59.7% in year 1 to 73.2%, which is a massive increase. And that was both for insulin and levodopa. Levodopa increased by 9, nearly 10%, and insulin increased up over 17%. And that got me thinking back to our own department. When we started this QIP, we used to put a diabetic tab on patients, but we couldn't tell who was on insulin and who wasn't. So that, if we can at least do that, that is a good thing. But what this hasn't shown is that, or what it has shown is that even if your department is overcrowded, if you get ED reception to identify people, they can still do that when the department's busy. What Northampton haven't been able to do is prove that increasing the mean in the SPC chart for standard 1 has increased standard 2, because their standard 2 didn't increase this year. But they've put in plans in year 3 which are in place already. So they put in an automatic TCM prescribing task, which is the second chain, which encourages and empowers the triage nurse and the assessment nurse to go and get them prescribed, as long as there's no contraindication. And then they're focusing on a stronger focus on self-administration in the ED. So the foundations are set, and we'll see what the results are next year. I don't expect the SPC charts nationally to change until year 4. I think it's going to take the year 4 to see a change. So we may see a slight change at the end of year 3, but year 4 is going to be the actual impact. So that was Northampton. In the Royal Derby Hospital, so year 1, their data collection, they didn't have enough data in year 1, but year 2, they introduced two simple things. So the Royal Derby Hospital has the highest percentage in the UK for people getting their time critical medication within 30 minutes. And they did 2 simple things. Number 1, they introduced a twice yearly time critical medication educational session for ED nurses. So it's just part of the normal education program. And then they ordered 5,000 yellow wristbands, which basically said time critical medication on them. And anybody who came into the ED on insulin or on levodopa for Parkinson's had a yellow armband put on them. Now, you might say that's expensive, because 80% of patients with Parkinson's who come in to EDs, 80% were admitted. So it's not like when you used to go to the swimming pool whenever you were younger and you got a red band and you were told to get out whenever your time was up. You're not going to get them back, because they're going to go up to the wards and they'll go home with them. So you can only recycle about 20% of them. But that's not the point. The point is that the implementation of that basically caused them to have a very strong performance in year 2, with an average of 67.9% compared to the national average of 33.8. So it's double. Their performance is double the national average. And when you split that down, if you break it down into levodopa and insulin, the levodopa percentage was 80.1%, which was absolutely fantastic. So it's an amazing number. So again, because their percentage was so high to start with, there was no immediate step change in their mean, but they've established a really strong foundation for year 3, and they're going to focus on supporting self-administration in line with the advisory statement that the college produced in April last year, which talks about show, assess, allow, aid, and monitor. So on the next slide. Oh, so that's all we've got. So hopefully we have been able to get across results of the 3 standards, and give you a couple of case reports to reflect on, to see whether whether anything that rings a bell and anything that you can do to help you in year 3 and year 4. So there's just a few questions on the screen. We're happy to take any questions. You can look at those 3 questions. If anybody wants to put a hand up, put something in the chat. I'm very happy to try to answer anything that you want to know.
I'm going to just unmute a couple of people, if that's okay. Shazad, I'm going to start with you. Let me just pop your mic on. There you go. That should be ready if you want to ask a question.
Sorry, can you hear me?
Yes,
Yep.
we can.
Oh, yeah. Thank you very much. Amazing results from Derby and Northampton. Brilliant results, and well done the audit team for conducting and carrying out this amazing survey, this audit QIP, in fact. My main question is that things are changing now because of the crowding and exit block in the departments. Now, our department is expected to prescribe all medications, including time critical, for our patients. How you see the future of this time critical medicine QIP in future? Because if the departments, most of the departments, I'm not sure about the other, but definitely our department is expected to prescribe all medications regardless time critical, non-time critical, because of the departmental pressures and exit block delays in medical teams to review patients. How we can carry out this QIP in future?
Yeah, so I think you need to be quite firm with the managers or whoever's trying to implement that. My view is that time critical medications should be prescribed within the ED. So definitely levodopa for Parkinson's, all Parkinson's medication, and also insulin for diabetes if it's appropriate, if they don't need that intravenous therapy. The business around do you need to prescribe all their drugs? I don't think that's our job. There is an argument that we maybe should prescribe all the drugs that are on the mist, mnemonic, but there needs to be a bit of give and take with the admitting team, because I don't think we have the time to prescribe all drugs. But we should be prescribing the time critical ones, because they are the most important ones if they're missed.
Can I add something, please? I agree what you're talking about. I don't have any issues with that. No one should have issues, but it's because of the crisis we are in NHS and the exit block is, I think departments are struggling right now. And we are all, I think most of the departments are expected to do things which they were not used to do. The corridor care is one of those things, plus these medication prescribing regulars is part of nowadays our job. So that's why I brought up this particular issue.
Yeah, I mean the other point is that if they are prescribed, it is the ED nurses that would have to give them, because there's no nursing staff that come down into the ED for patients that are waiting to go up. So it really does need to be worked out at a local level, because it is that's the next bit that needs to be looked at. But if we need to concentrate on getting levodopa prescribed, insulin prescribed appropriately, and getting the ED team to administer those drugs. And then once we get our house in order and we get that done effectively, and we see improvement, well then, we're up for the rest of it can be discussed, in a sensible manner, is what I think. Ali?
Yeah, I totally agree with what you're saying, and I understand your predicament, Shazad. But what I'd say is use these results, both national and local, to have that debate with your local managers, because you could say, look, we're not even getting this right in the ED for time critical meds. So, it's the ED job potentially to ensure time critical meds are prescribed for the time they're in the department. And if we don't get that right half the time, there's not much hope that we're going to get all their regular meds right. And we have to be able to prioritise. So, whilst everyone should ideally have all their meds whilst they're in the department, we have to be able to prioritise and use these results to your advantage to say, actually, locally, we want to work on the time critical meds, getting those right for the time they're spent on corridors within your department. And our priority can't be every other medication, because you haven't got the nursing time to even administer them, or the pharmacy time to even get the drugs.
Because the priority is shifting now from time critical to the regular medications now. So that's the main challenge at the moment. Anyhow, that was my observation. I thought I'd better share with you.
Thanks.
Thanks, Bethany. You should be able to unmute yourself now.
Thank you. I agree with quite a lot of what's already been said, and I do think that from a nursing perspective, it is very difficult, as has already been said by you, Johnny. There is no additional nursing staff that come down to the ward to or even just put on to ED to make sure that patients get their time critical meds. But I do think it's a big patient safety issue. Patients who don't get their meds are at risk, which presents a risk to the hospitals as well. And I've been in the position, so I'm speaking from a position of knowledge. This will have, for them, it won't be a time critical med, it'll be a money critical med, because that patient potentially is going to be knocked back completely avoidably and end up being in a bed that they didn't necessarily need to be in, taking longer to recover because they haven't had time critical meds. Therefore, there's lots of patient safety issues around that, but there's also a financial issue around it. And I think that we kind of need to change our thinking around it, because as clinicians, we just want the very best that we can get for our patients. And the trust will think slightly differently. And we know they do. And that will mean that if we can align somehow this as a patient safety issue, alongside, in England anyway, align it with a CQC standard, all of a sudden, both financially and from a CQC perspective, trusts will start to open their ears and listen, because there is no doubt, or flow from EDs is very difficult. Extremely difficult. And we have patients who are suffering avoidable harm because of overcrowding and lack of flow. So maybe one way in which senior ED staff, managers in ED can address the issue with senior managers within their trust is to look at it from patient safety, and I'm sure you already have done, but also aligning it with your regulatory bodies, because this is an appalling situation. And it has consequences, health consequences for our patients. It has cost consequences for the trusts as well.
No, absolutely. I totally agree with that. It is quite difficult. I think people have found it difficult to get engagement with sort of management and higher up levels. What I've said to some departments and some trusts is there was an HSSIB report back in December 2024 of an elderly gentleman who went to a surgical outpatient clinic in the morning. They thought he had a bit of abdo pain. It might have been obstructed, so they sent him to the ED for assessment. He shouldn't have come to ED in the first place. Should have been fast tracked to surgical triage. But he actually was admitted. He spent, I think, 72 hours on an ED corridor, and out of his 20 levodopa doses, he had 11, of 3 of which he self-administered himself. at the start. And he then went to the ward and aspirated, got a pneumonia and died 4 weeks later. And what I've said to departments or leads is take that report, bring it to your chief executive and say, can you tell me that this would not happen in my hospital today? And if they say that won't happen, that's fine. But they won't, because they can't guarantee that it won't happen. It could happen, and that could happen in any emergency department across the country today, and that's the difficulty. And I think once the trust people that have gone to the trust boards and chief executives with that report have started to get buy-in, and that maybe somewhere to start for people that are struggling. The other issue is around self-administration. So we in Leicester were able to increase our self-administration rate from 11.1% to 23.2% in year 2. And that was really using a pragmatic approach by the nurses. So our chief pharmacist is against self-administration within sort of the ED, because it doesn't follow the self-administration of medicines policy, but it doesn't work in the ED, so we need to have a pragmatic approach. So we're still working with them to try to work out what's the best way to do it.
Bethany, do you want to go ahead quickly, and then we'll go on to
I just wanted to come back on that. Johnny, I absolutely agree with what you're saying here, and I think there is a real need to align with patient safety bodies and our regulatory bodies, because what I'm about to say is going to sound very controversial. And again, I'm speaking from experience as a former director in the health service. Death carries no cost unless it's proven that there is that the trust is at fault, and that's often very, very difficult to prove. So I would certainly advocate using patient safety mechanisms and your regulatory bodies as your bargaining power, because and you know what, use your personal experience. My mum was a Parkinson's disease patient. I certainly have had conversations around with clinicians around her care when she was still alive. So yeah.
Absolutely. So how would we do that then? What do you think we should do? What would you do? What should we do from a college point of view then? So this report will go out today, and what do you think we should do as a topic team to try to get that ball rolling?
I think one of the things that I can do, so for those of you who don't know who I am, I'm the Director for Clinical Quality Improvement at the Royal College. And I think one of the things that I can do, because I've got quite a substantial, a pretty good experience of working with the CQC and helping trusts to align and improve. And I think that's something that it's difficult to do. Without a doubt, it is difficult to do, especially if you've got fairly closed shop management within your trust. But there are ways to do it. And I think, to be honest, Johnny, that would be a conversation. It's so detailed. It would be a conversation out of here. And I'd love to have that conversation with you, because I do think that from TCM, this is so important. I think we need to develop the steps to getting there for our colleagues across all 4 nations, because I'm sure there is we know that overcrowding is a problem across all 4 nations. I think I think perhaps you and I and the rest of the TOFIC team go together to look at how we can best implement this, because one of my small concerns is about relying on reception staff, i.e. an agenda for change band 2 identifying a patient on a TCM. I just think we need to, again, to be very clear about the methods that they're using, A, to identify, and B, to escalate that to a clinician.
Yeah.
But again, I think it fits, because if we come back into the round, it fits the patient safety agenda.
Yeah.
That is as early as you can possibly identify. So let's make sure that we do it really, that trusts are going to listen, if you like. And when I say trust, senior trust management, those people who've got the capability, shall we say, to make the changes that we need to see in our EDs.
Yeah, no, that'd be brilliant. So maybe Amy could send around the dates of the next TOFIC team meetings and see if you're free to come to one of those. Well, that'll be really welcome. So yeah, definitely.
That'd be really good. Yeah.
Yeah. Thank you. Super.
Ali.
Yeah, thanks for your support with that, Bethany. I think it's really important that we have those conversations going forward and drive the safety agenda and what can be done sort of national level to make a difference. But I also think there's some things within our control in each local ED department, isn't there, that we can increase the proportion identified and get their medicines prescribed. And then we can use the data at local level to have the conversations with managers about how we're going to support our patients to actually get these medications. So, for example, Shazad, I think you mentioned, the nursing time. Well, use your data to say we haven't got the nurses to give these medications. Time critical medication is a safety issue, as Bethany's clearly articulated. If we want to get this right in our hospital to prevent harm like the stories Johnny shared, then you have to help us have some staff to come down and help give the medication. If you've identified them and they're flagged, then that should be an easy option for the managers to say, right, they're identified, here's your help today to get, the 10 patients in the department right now who are on time critical medicines. But, it's not going to work unless they're identified, and that is within the ED's control. So I think data doesn't change behaviour, does it? But it helps you have the conversations with the managers so they can't ignore that this is not a problem in your ED department.
Yeah, I know also that some departments have employed ED pharmacists who will are identifying, picking up and prescribing, so they're getting their time critical medications. So that's potentially another avenue to go down and get recruitment into. So there's lots of ways we can improve over the next, from where we're at now to where we're at, hopefully trying to get to.
Brilliant. I have one question from Hannah. It was, did the yellow band at Derby mean admitted patients were better managed for TCM whilst in?
So I don't know the answer to that question. I do know this is terrible. I do know that the trust wouldn't fund the wristbands, and the ED consultant paid for them themselves, which I think is absolutely shocking. But I don't know what happened after they went to the wards, which would be interesting to see. Did it make a difference? So I could ask them to find out.
Brilliant. Back to Bethany.
Sorry, I'm Johnny, you just nearly made me fall off the chair then.
I know, it's crazy, isn't it? It's crazy. I couldn't believe it. It's absolutely bonkers.
Ludicrous.
It's
utterly
bonkers.
Ludicrous. It makes my blood boil.
Yeah.
And again, guys, this is about patient safety. Cost of a bed occupied by a patient that does not need to be there, because if we'd given them their time critical meds, we could have sorted them out and they could have gone home. So an additional, and we all know, sadly, with Parkinson's disease patients, miss a few doses, you might as well knock that patient back 3 weeks. And it's going to take that long for them to recover. So, you know, start using pound signs is what I'd say, because certainly at the moment there are such financial constraints on services and particularly acute services that, you know, I'm afraid pound signs actually works. And the argument of cost of a box of yellow wristbands, and there's about 1,000 wristbands in a box, against the cost of an avoidable stay in hospital. So you guys might need to do a little bit, because with any QIP, something else falls out of the QIP. And it might be that you need to look at how many patients perhaps with Parkinson's, because that data is easily available, and the Parkinson's Disease Society can help with that. How many in your hospital have had an avoidable stay, and run a cost comparison? Because I think a box of yellow wristbands probably costs about, I don't know, if it costs 20 quid, I'd be surprised. But a cost of a bed overnight is a hell of a lot more.
Yeah, I've just put something in the chat, a link, Bethany, which Parkinson's UK did a dashboard for ICBs, that basically, if you put in your data for your hospital, so this might be somewhere to start. If you put in the data for your hospital, it'll work out. It works out using algorithms how much you'll save if people get their medication on time. So it's already there. It's there to be used, except nobody knows about it. Nobody's using it. So it would be great to have a look at that, to see how that could be used to influence this conversation to improve care, because that will bring in the financials. That'll bring in the financial savings. Because we've tried. You're right. We've tried like stickers. We've tried. You know, we're trying sort of wristbands. We're trying, you know, self-administration. But we need to basically, you know, money talks, doesn't it? And we need to start getting people at a higher level to perk their ears up.
And I also think, Johnny, sorry to come back in, and sorry, Shazia, I know you're waiting to come in, but there is just one more thing that I really would like to say, is that please don't assume that because of overcrowding in our EDs, we cannot do this as ED clinicians, because we can.
Yeah, I agree.
We just have to think differently.
Yeah.
And you know what? If you've got a group pharmacist who doesn't really want to cooperate or go with you on the journey to patients being able to self-administer, challenge it.
Yeah, absolutely. Thanks. That's so helpful. So helpful. That's great.
Shazad, you are back up.
Yeah, thank you very much. Actually, most of the time, these patients are the walking patients. They already, or even they may be with the ambulance, but they bring their own medications most of the time. So I think most of the time, pharmacy is not a big issue. Issue is that who is going to identify these patients first, because our triage is becoming now more complicated. It's tier 1, tier 2, then they are seen by the doctors in our trust. So again, triage is complicated process. Then you have a doctor to find, and he will prescribe. Then this will be delivered. So this, I think, because of the bureaucracy, because of these other barriers, that's maybe the reason why the results are not achieving the target. Is less than 50% almost every year since it was started. This is a system issue. I think it's more like a system problem, which is, we can't underestimate the issue, what the system failure is like. And these are the barriers these are causing issues delivering the medication within 30-minute duration.
Yeah, I mean, I think you're right, but I think, you know, we are seeing an improvement. So we would expect standard 1, standard 2, standard 3, but actually standard 3 is the one that's got better the most. So we're consistently once we identify and it's been prescribed, we're getting better at giving it, which is really, really good. So it may be that the improvement comes 3, 2, 3, 2, 1, or 1 doesn't have an effect and 2 and 3 do. I don't know. I just know that you know, there's still a lot of work to be done, and you know, I do appreciate that this QIP is hard work. It is hard work getting the data and putting it in, but if you can just keep going with it for the next 18 months, I think the results that we'll get, hopefully, will with everything that's been discussed today, we'll start to see real change. Thanks.
Sorry, just last question, maybe last question. Although you're focusing on levodopa and insulin, but if the patient is on other time critical, we can't enter the data. This is only specific for these 2 drugs, if I'm not wrong.
Yeah, that's right. So basically, we talked long and hard about this, whether we would include other medications. We came to the conclusion that because insulin and levodopa are really they're the only 2 truly time critical medications. I know Trusted has a list of 183 medications that they think are time critical. How you remember all those, I do not know, but all you can remember levodopa and insulin. So what we've said within the topic team is the systems that are put in place for Parkinson's meds and insulin should be adopted to the other missed medications as well. So if you're going to put in depending on what you do, it's easy to replicate the change or the intervention that you've done for those 2 for the rest of them. But there's a difference between missing the dose. So you miss a dose of your anticonvulsant, you miss a dose of your warfarin, your apixaban, it has an effect. But if you delay it by an hour or 2 hours, it's not going to make much of a difference. Whereas if you don't give somebody their insulin related to their food, or you don't give somebody with Parkinson's their medication 2 hours late, they're going to have clinical deterioration quite quickly. So it's important that we focus on those 2, but the systems that are put in place can be adapted to the others.
Yeah, thank you.
Brilliant, thanks. I can't see any more questions in the chat. There are still a couple of questions on the slides, but unless we've covered them. Yeah.
Great, that's super. Yep.
Brilliant. So if there's no more questions, then thank you everyone for joining. I really appreciate all of your discussions, and thanks Johnny and Ali for supporting us with this. It's some great work and we're getting some good results out of it, so that's great. So yeah, as I said, this will be up in a couple of weeks for you to look at, and the national report is up now, so go have a read of that. And yeah, thank you all. We'll catch you soon. Thanks.
Thank you. Bye-bye.
Bye.